You're welcome.
I think other students will come in as we go. I just posted in another group where I think most students are. I think they're coming.
Oh, you think they will come or not?
They will join us as we go.
Ah, okay.
Yes,
So you prefer to wait for them or not?
I think let's continue. Then they'll just catch us up when we are going on.
Ah, okay.
Yeah.
As I told you, today we want to speak about abdominal pain in children. Like vomiting, it's another important symptom in children and who come to our hospital to be visited by us. Um, at first, in a child presenting with abdominal pain, it's important to find the diagnosis at the shortest time. And like other symptoms, at first it's important to rule out the most important diagnosis. Okay. Now I want to name some of red flag signs. The first one is bilous vomiting. As I told you last session, if the vomit is bilous, then it shows that you have obstruction in your gastrointestinal system, and the site of obstruction is below the second part of the duodenum. Another red flag is bloody stool or emesis, and another one is nighttime waking with abdominal pain, also hemodynamic instability and weight loss. As you know, for example, like a headache, when, for example, abdominal pain or headache, waking up the child, at night, it's very important because it shows that the pain is really, really annoying for the child. Okay, here you can see some of the most important things that you should ask while taking history of your child. The first is place and location of the pain. You should ask about the location of the pain, and for example, sometimes the child uses one finger to locate the pain, or in other cases, the pain is diffuse and poorly localized. Another important thing in the place and location is to ask about the changes in location of the pain. For example, as you know, in appendicitis, first the pain is pre-umbilical, and after, for example, 1 day or, for example, 12 hours, the pain will be located to the right lower quadrant. So it's important to ask about the changes in pain location. Another important thing is about radiation. Pain can radiate from its point of origin in any direction. For example, in gallstones, the abdominal pain radiates to the shoulder, or in pancreatitis, it radiates to the back. And another thing is severity. You can ask your child to tell you a number between 1 to 10, and it shows the severity or degree of pain. But we have some limits in children. In older children, it's possible to ask them to tell you such a thing. Another important thing is timing and onset of pain, duration of pain, and also course during the day. For example, in last session, we talked about cyclic vomiting syndrome, and I told you that the abdominal pain in that syndrome is mostly in the morning. Um, so if you ask about such characters, then you can find your diagnosis. And also about occurring the pain at night or not. Another thing is alleviating factors, anything that reduces the pain, like body position, movements, or medication. For example, in pancreatitis, if your child sits in a position with flexion of the hip and also straightening of the back, then the pain will be relieved. Or for example, if your abdominal pain is due to peptic ulcer disease, then taking medicines like, for example, H2 blockers or PPI can relieve the pain. And another factor is aggravating factors, anything that increase the pain, like body position movements and relation to food intake. We should ask about bowel movement patterns and stool quality. For example, about past medical history of constipation or diarrhea, and also about the size of, for example, in constipation, we should ask about size of the stool that the child passes, and also about the odor of the defecation. Ask about ingestion of toxin or foreign objects. For example, in very young children, they may eat something, for example, I don't know, a coin or something like that, and it can cause this abdominal pain. Accidental or non-accidental trauma is also important in abdominal pain. We should ask about dietary history. For example, eating food out or in unhealthy places is very important. And asking about past medical history. For example, here we can see some examples that are very important. For example, in cystic fibrosis, the child will be predisposed to gallstone. So if you ask about past medical history and your child has chief complaint of abdominal pain, then you should be suspected about gallstones. In spina bifida, cerebral palsy, developmental delay, it's important to be suspected about constipation as a cause of, abdominal pain. In sickle cell disease, also splenic autoinfarction may occur and it causes a very bad abdominal pain. Recurrent respiratory tract infections such as mesenteric adenitis. As you know, we have lymphadenopathy in our abdomen, and in respiratory tract infections or other infections, they may be large, and it causes pain in the abdomen. We should ask about sexual history, screening for sexually transmitted infections in females. We should ask about menstrual cycles. It's very important, regularity, amount of bleeding, and relation to abdominal pain. And also past medical history of, for example, diseases like endometriosis is very important. And family medical history, especially inflammatory bowel disease. As you know, IBD occurs more in families who have another member with the same disease. We should also ask about travel history, social, and psychiatric history. If you have any question, you can ask me while I'm teaching. Okay, in physical examination part, at first, the vital signs is very important, and also growth parameters. For example, if there is any evidence of failure to thrive, FTT, then, for example, in a child with cystic fibrosis and, FTT and abdominal pain, I told you some diagnoses like gallstones will be highlighted. Another important thing in physical examination is inspection. You look at the abdomen for searching for symmetry, pulsations, peristalsis, skin markings, and wall protrusions like hernias, any signs of trauma, bruising, swelling, and abdominal distension. Can you tell me if you see pulsations? in inspection. Then what differential diagnosis do you think are important?
The problems like maybe there will be aneurysms, especially up aorta aneurysm.
You mean aortic aneurysms? Ranka, I can't hear
Yeah,
you well.
yeah.
Yeah, aortic yeah, very good. Okay, another important thing is auscultation. You should auscultate before palpation in the abdominal exam and listen for bowel sounds. As I told you last session, in diseases like ileus, the bowel sounds will be decreased, and it's important sign for obstruction. In percussion, you should assess general tone, tympanic versus non-tympanic, percuss for level span and spleen tip, and assess for ascites. For example, if you have ascites, then in percussion, or for example, if you have many gas in your abdomen, it's tympanic. Or if you have a large mass, solid mass, or splenomegaly, then your percussion will be non-tympanic. In palpation, you should assess tenderness with light and deep palpation, assess for guarding and rebound tenderness, palpate for liver, spleen, kidney, and abdominal masses, including fecal mass. And in digital rectal exam, you should examine the anus for fissures, skin tags, and then assess for tone, stool, and blood. Okay, again, can you name a disease which digital rectal exam is very important and you can find some important findings in examination? Okay, I can name in IBD, Crohn's disease. If you do the digital rectal exam, you can see many fissures and skin tags. So it's very important and we shouldn't miss the digital rectal exam. Okay, now I want to talk about differential diagnosis in acute abdominal pain. I'm going to read them quickly. It's a good review for you and to have all of this in your mind when examining children with abdominal pain. It can be due to GI sources like appendicitis, pancreatitis, intussusception, malrotation, inflammatory bowel disease, gastritis, bowel obstruction, mesenteric lymphadenitis, and IBS, irritable bowel syndrome, abscess, hepatitis, perforated ulcer, Meckel diverticulite, and cholecystitis, constipation, gastroenteritis, and abdominal trauma. Renal sources like UTI, urinary tract infection, pyelonephritis, and nephrolithiasis. And also genitourinary source like ectopic pregnancy, ovarian cyst or torsion, pelvis inflammatory disease, and testicular torsion. Oncologic sources like stoma, neuroblastoma, and lymphoma, and other sources like Henoch-Schönlein purpura, pneumonia, sickle cell anemia, diabetic ketoacidosis, and incarcerated hernia. Okay, now the diagnosis, the history and physical examination I told you at first, and radiologic studies. In radiologic studies, you should obtain the abdominal radiography to assess for obstruction, constipation, clear, gallstones, kidney stones, or for example, in lower lobe pneumonia, you should take a chest X-ray to evaluate for pneumonia. I'm sorry. Also, in for example, appendicitis, the abdominal pelvic ultrasonography can help you, or in traumas, for example, abdominal CT will be helpful too. Laboratory studies like electrolyte chemistry panel, complete blood count, liver and kidney function tests, coagulation studies, blood type, and urinalysis, amylase, lipase, a culture of STD, and beta human chorionic gonadotropin, beta ICG, and ESR and CRP are helpful too, but actually you don't need to ask all of them for every patient with abdominal pain. You should have the differential diagnosis list in your mind, and by taking a good history and examining, you can rule out them. Here you can.
For radiologic studies, which one is like the first before we go to other specialized imaging?
Okay, actually, I told you, for example, in constipation or obstructions,
Yes.
the X-ray will help you more than ultrasonography at first, and the radiation is very low. You can't ask CT scan for every patient because of the radiation, and also, for example, in some situations, like for example, you are suspected to appendicitis, the ultrasonography will help you more than the X-ray. But in many cases, like for example, constipation, obstruction, or pneumonia, you should ask for X-ray at first. Or for example, if you are suspected that your child may eat something like coins or batteries, then the X-ray will help you more.
Okay.
Did you get your
Yes.
answer?
Yes. Yes, I got mine.
You're
Thank you.
welcome. You're welcome. Here you can see a whole schema of the abdominal pain. In the assessment of acute abdominal pain, the type of pain is very important. For example, if it's sudden onset, then differential diagnosis like testicular or ovarian torsion, intussusception, volvulus, perforated, viscous, and incarcerated hernia are more important. Or in episodic pains, constipation, gastroenteritis, intussusception, mesenteric adenitis, and ovarian torsion also are important. In appendicitis, the important thing is that your pain starts, and after that, the degree of pain will be increasing gradually, and it's a steady pain. It's not episodic or colicky, it's steady. In episodic pains, differential diagnoses are here. For example, if your pain is episodic and also you have bloody diarrhea, gastroenteritis, Meckel diverticulum, and inflammatory bowel disease are important. But in Meckel diverticulum, actually the pain isn't so much, so much hard for the children, and actually the most important symptom is bleeding. Also, if you have pain and bilious vomiting, then the volvulus and obstructions can be the reason. In polyuria, polydipsia, and weight loss, diabetic ketoacidosis is important. In vomiting, plus diarrhea, plus abdominal pain, gastroenteritis is on top. And in cough, fever, and episodic abdominal pain, then you should think about pneumonia. And also you have urinary tract symptoms like dysuria, frequency, and fever, then you should think about UTI or pyelonephritis. Okay, now I want to talk about some important diagnoses, acute pancreatitis and intussusception, and also appendicitis in children. I'm gonna talk about them quickly. I think it's important to know about them more precise. So I have chosen these three diagnoses. Acute pancreatitis in children. You know, pancreatitis is inflammation in the pancreas. The pancreas is a long, flat gland that sits behind the stomach in the upper abdomen, and it produces enzymes that help digestion and hormones that help, like insulin, that help regulate the way your body processes glucose. And in children, you know, in adults, some etiologies like alcohol consumption are very important to cause pancreatitis. But in children, blunt abdominal injuries and multi-system diseases such as hemolytic uremic syndrome, inflammatory bowel disease, biliary stones, and drug toxicity are the most common etiologies. And in drugs, valproic acid, L-asparginase, and 6-mercaptopurine are the most common causes. You know, L-asparginase and 6-mercaptopurine are mostly used in chemotherapy. Um, the patient with mild acute pancreatitis has moderate to severe abdominal pain, persistent vomiting, and possibly fever. The pain is epigastric or in either upper quadrant, steady, often resulting in the child assuming an ontalgic position, as I told you at the first, with hips and knees flexed, sitting upright, or lying on the side. I'm sure that you have seen these children. In the management of
I've
pancreatitis,
seen them.
yeah, very nice. In the okay, tell me.
I
I'm
I
listening
wanted
to you.
to I wanted to ask on mumps. Is it a major mumps virus? Is it a major cause of concern in terms of pancreatitis?
It can cause, but actually, you know, because of vaccination,
Yes,
um,
yes.
nowadays we don't see it as a main cause of pancreatitis. Actually, in children, trauma and using sodium valproate, as you know, for example, in cyclic vomiting syndrome, in migraine, you know, in epilepsy syndromes, many children use them, so you should consider it.
Uh-huh. Thank you.
You're welcome. And in the management, we should, in the first hours, make sure that the patient has nothing by mouth, and we can fix a nasogastric tube for our children, and also hydrated with IV fluid therapy. We should do serial abdominal examination and also surgical, gynecological, and GI evaluation. It's important not to miss other diagnoses, for example, in perforated ovarian cyst or something like that. So you shouldn't miss other diagnoses. And also pain control, and our choice is morphine and antibiotics as indicated. As you know, we don't prescribe antibiotics in pancreatitis for every child. Actually, if, for example, there is any side effects of pancreatitis, like pseudocyst, then it's important to prescribe antibiotics, not in other cases. In the workup, we ask laboratory the amylase, lipase, and also abdominal sonography. Serum lipase is considered the test of choice for acute pancreatitis because it is so specific, and also the serum lipase rises by 4 to 8 hours and peaks at 24 to 48 hours. Coagulopathy test, leukocytosis, hyperglycemia, because of the the act of pancreas in regulating the glucose level of the serum, hypocalcemia, elevated gamma GT, and hyperbilirubinemia. Okay, the next important diagnosis is intussusception. Intussusception is the most common cause of intestinal obstruction between 5 months and 3 years of age, and the most common abdominal emergency in children younger than 2 years of age. So if you saw a child who is, for example, 6 years old, and in the report of abdominal sonography, they reported intussusception, then you should be suspected that maybe the diagnosis is wrong, or you have pathologic lead points. For example, if you should think about malignancies, or maybe a tumor or things like that, that causes the intestines to go to each other. And also, ileal colonic intussusception may lead to intestinal infarction, perforation, peritonitis, and death. Lead points are more common in children older than 2 years of age, as I told you, and intussusception are most often ileocolic. In the intussusception, the upper portion of bowel imagines into the lower portion, pulling its mesentery along with it into the enveloping loop. Constriction of the mesentery obstructs venous return. Engorgement of the intussusception follows with edema and bleeding from the mucus that leads to a bloody stool, sometimes containing mucus also. Most intussusceptions do not strangulate the bowel within the first 24 hours, but can eventuate in intestinal gangrene and shock. So it's very important that you diagnose it very soon and treat the child, because if it prolongs, then side effects like gangrene and infarction in the intestines may occur, and it's very bad. As you can see in this picture, the upper portion of the bowel imagines into the lower portion, and also the vessels may be infarcted, or the blood can't get to the intestines, so infarction may occur. Here you can see the typical stool of patients with intussusception. This stool is called current jelly stool. Actually, blood is generally passed in the first 12 hours, but at times not for 1 to 2 days, and infrequently not at all. So if your child doesn't pass the current jelly stool, you can't rule out the diagnosis of intussusception. You should put many things together to decide about the diagnosis. And also 60% of infants passes to containing red blood and mucus. That is called current jelly stool. And the classic period of pain, palpable sausage-shaped abdominal mass, and bloody or current jelly stool is seen in less than 30% of patients. Another thing that I want to tell you about intussusception is that the character of abdominal pain is very important. If you have noticed in children with intussusception, you can see that they're nagging and crying, for example, for 1 hour, and then you can see the pain will be stopped, and they go to sleep. And after that, the pain will start again, for example, for 1 hour or another period of time. So actually, the pattern of the pain is on and off, and you should pay attention to it. Reduction of an act. Okay, then.
Yeah, I want to ask, what really is the pathophysiology behind the pain of intussusception to go and come back, go and come back? what
Yeah.
will be happening when there's no pain? I'm just wondering, is there any movement or?
Yeah, actually, when the vessels, for example, there is a pressure on them, then the amount of blood that is going to your vessels will be reduced. With movements, for example, or we don't know, maybe movement of the trigger point or things like that, this pressure will be reduced, and the amount of blood that goes to the intestines will be normal. And it's very important, in the pathophysiology of the pain. As you know, for example, in diabetic ketoacidosis, or in any situation that the amount of blood that goes to your intestines are decreased, then you can see the abdominal pain as a sign. For example, in diabetic ketoacidosis, because of the acidosis, you can't, the intestines can receive enough blood, and because of that, you can see abdominal pain in those children. So it's important, reduction of acute intussusception is emergency, because before the gangrene and infarction of your intestines, you should do something about it. Okay, did you get
Yes,
your
yes,
message?
yes, I understood.
You're welcome. In patients with prolonged intussusception and signs of shock, peritoneal irritation, intestinal perforation, or pneumatosis intestinalis, hydrostatic reduction should not be attempted. So, generally speaking, the main treatment of intussusception is, reduction by sonography. But in situations where we have signs of shock or peritoneal irritation, intestinal perforation, or pneumatitis intestines, where you see the air in the intestines in the X-ray, the choice for treatment is surgical. In this picture, you can see surgical reduction of the intussusception. They're pulling out. Okay, here is some differential diagnosis for intussusception. When you have rectal bleeding and vomiting, you should think about mecal diverticulum, bacterial colitis, malrotation. Also, another important thing that I want to tell you is that pathophysiology of intussusception. In Children Medical Center, we see that in some families, for example, all of their children experience intussusception in some specific ages. So it may be that some genetic factors can cause intussusception, and also infectious etiologies are very important, such as Yersinia, Salmonella, and Shigella. And if it's not in the usual age for intussusception, then you should think about pathologic lead points, like, for example, malignancies. Okay, the last important diagnosis in children is acute appendicitis. As you know, the most common acute surgical condition in children and a major cause of childhood morbidity is appendicitis, and is mostly associated with complicated perforated appendicitis. Infants with appendicitis are often misdiagnosed with sepsis because of their diagnostic delay they present in advanced stages of the disease. In contrast to gastroenteritis, abdominal pain in early appendicitis is constant, not cramping or relieved by defecation. And also in last steps, the emesis may become bile stained and persistent. It's important to know that, because the infants can't talk well, or tell their families about the symptoms. Then it's very important not to miss the appendicitis in children with abdominal pain. Okay, here you can see the pediatric appendicitis score. There is some, differences with adult appendicitis score. Scores. The important thing is that cough, percussion, coughing, tenderness get two numbers of the 10 in the, score chart. So you should ask about this, and in examination, you should consider uh, this. Perforation is common beyond 48-hour of illness, and early appendiceal inflammation results in pain which is poorly localized and preumbilical. So at first, the pain is poorly localized and preumbilical, but progression of the inflammatory process in the next 24 hours resulting in somatic pain localized to the right lower quadrant. So at first, you may just see a poorly localized pain or a preumbilical pain. In the pediatric appendicitis score, so the importance of this score is for treatment. For example, if your score is less than 4, it suggests that the likelihood of appendicitis is very low. So you should consider other diagnoses. If the scores are more than 8, then it's highly sensitive and specific for appendicitis, and you can consult with surgeon and talking about surgery. And intermediated scores between 4 and 8 on the pediatric appendicitis scores are considered inconclusive and typically trigger advanced imaging studies. For example, you can ask abdominal ultrasonography to help you, or abdominal CT to help you to decide. And the treatment, operation should proceed semi-electively within 12 to 48 hours of diagnosis. Children with appendicitis are typically at least mildly dehydrated and should receive supportive care prior to surgery. So you should give them IV fluid therapy, and because of the vomiting, they may have some degree of dehydration, and you should give them enough fluid. And electrolyte abnormalities, antipyretics to lower fever, and broad spectrum antibiotics. Antibiotics should be initiated promptly once the diagnosis of the appendicitis is made or highly suspected. We prescribe the first dosage of antibiotics just before the surgery, and we continue it until 2 or 3 days after surgery. And also the time of treatment depends on adverse effects, or maybe, for example, the surgeon uh, in the surgery saw abscess or something like that, then you should prolong the antibiotic treatment therapy. Okay, if you have any questions, I'm here to answer you.
And I don't have any questions. It was excellent. Thank you so much, Doctor.
Thank you very much. I'm so happy that you like the class, but I will be glad if the number of participants will be more in next sessions. I'm not sure if the time is not suitable for them, or the day. You can tell me, and also I will be glad if you tell me your preferred actually topics.
I think today is like we are coming from exam. We had OSK. So,
Yeah.
and for this group, this is the last exam in pediatrics. So,
Oh.
yeah, so they just finished it. So I understand that's why they didn't come, because they felt as if we've completed the course. But
Yeah.
I'm talking to a new group, the group which is coming. I'll be also working with them to continue this program.
Oh, it's very nice. I'm so happy to meet you. I hope that these sessions will be continued. Okay, don't you have any question?